So the study is called ERADICATE-AF, and it was designed to test the value of adding renal denervation to a standard ablation procedure or pulmonary vein isolation in patients with paroxysmal atrial fibrillation and hypertension. We ultimately randomized more than 300 patients, and the clinical characteristics of the patients was very well balanced. What we found was that the renal denervation procedure could be performed very safely. There was no increase in complication rates, both short-term and long-term, in patients who were assigned to that arm versus the standard ablation arm. And most importantly, what we found, there was a 43% reduction in the primary endpoint, which was recurrence of atrial fibrillation 12 months after the study procedure.
Renal denervation generally has a spotty history, and one of the questions is the thoroughness of the procedure. So how confident are you that the procedure you used was created a meaningful denervation and created meaningful effect on the patients?
Well, the one factor that gives me the most confidence is the ultimate clinical outcome. Nothing else was different between the groups except one group had renal denervation added to the ablation procedure. Otherwise, everything was the same. So that obviously gives me the greatest confidence. As electrophysiologists, we're very comfortable doing catheter ablation. We like imaging the target sites. We like placing the lesions very carefully, meticulously, methodically in all the right regions. We have a long experience doing renal denervation for antiarrhythmic indications, clinical trial work. So this was not new to us or any of the centers that participated. And we do a longitudinal spiral type ablation from distal to proximal end of the renal artery. And we deliberately always put in multiple lesions in every patient, and there was a very tight range, generally 6 or 7 lesions per renal artery. So just as in an anatomic-based ablation, we're comfortable, if not confident, that we achieve renal denervation. On top of that, we do in selected patients high-frequency stimulation, and that adds confidence to the technique we're employing in all patients. And B, in those patients who underwent high-frequency stimulation, we actually acutely demonstrated that there was no longer a hypertensive response to high-frequency stimulation within the renal arteries when we concluded our 6 lesions. And that gives us a basic feedback that we actually have performed, at least acutely, a denervation procedure.
What are the firm conclusions that you think you can draw from the study you've now done?
Well, in the target population that was participating in this study, which is specifically selected to be a relatively broad population. This is probably the most common subgroup we'll see in a busy ablation laboratory, patients with paroxysmal AF who have hypertension. We deliberately ratcheted down the nature of the hypertension, so it's no longer, quote, resistant hypertension, which has a formal definition. This is a much less severe variant of hypertension in the patients for this study. They were on at least one drug, and they had increased levels of blood pressure at study entry, but they were not that different than what we see in clinical practice, where many patients have less than optimal blood pressure control on a medical regimen. So we think, based on our study results, the renal denervation procedure is applicable to these patients at the present time.
Could you see using this approach right now on a routine basis?
Yes. I mean, if you increase the success rate from 55% approximately to over 70%, using a fairly liberal recurrence definition, that's a pretty big difference in outcome, and without any increase procedural risk and only about 20 minutes additional procedure time, I think that there is a lot of benefit for relatively little investment.
So you could see on selected patients using this procedure starting next week?
Again, I think the challenges will be, particularly in the United States, is that there are no approved renal denervation catheters. Now, we've shown in this and in several other studies in different populations, you can use standard ablation catheters. It's a little more time consuming, slightly, but we're comfortable with those catheters and systems. We have to dial down the energies we use and so on, but you can just pick up an off-the-shelf catheter that delivers RF energy using an irrigated tips system, and I believe it can be employed now. You have to develop institutional protocols to be able to do this procedure, I believe, but I believe it can be implemented at the present time. The one that we have in a concept phase is to do this in people who are not hypertensive, because that will fundamentally get at the mechanism of action of renal denervation. Does it work purely by reducing central sympathetic tone, and therefore that translates into an antiarrhythmic effect without change in blood pressure required, will be the most compelling next trial that we're going to perform.